Good evening, everyone. Welcome to our first session of this year for Ocular Genetics Interest Club. Today we have Dr. Tanmayi who will be speaking about choroideremia. Thank you, Dr. Tanmayi, first of all, for agreeing to do this and taking out the time to make that presentation. Dr. Tanmayi is a pediatric ophthalmologist and strabismus specialist with over 9 years of clinical experience. Her key areas of interest include refractive errors and amblyopia, squint and nystagmus, neuro-ophthalmology, and genetic eye disorders. She's done a specialized short-term training in ocular genetics at a university in Belgium. She currently practices at Hemdeep Clinic in Navi Peth and serves as a visiting consultant in pediatric ophthalmology and ocular genetics at several institutes across Maharashtra. In addition to that, she's also a professional dance trainer and choreographer, bringing creativity, discipline, and balance to all of her areas of life. We welcome you, Dr. Tanmayi, and I welcome all the listeners. I think we can start with your presentation now.
Okay, thank you, Nivedita, for the kind introduction. So I will just start sharing my screen. So Shailja came up with this idea of discussing cases and trials of the same disorder, which I think it's quite interesting and relevant so that we know what's going on with the treatment part of it in order to tell patients. And recently I got 3 patients of choroideremia almost back to back. So I read up on the ongoing trials and I found them quite interesting. So I said, let me present it so that I also read up more about it. So let's see the cases in brief. They are very routine cases. This was a 46-year-old male who came with the complaint of, actually he did not have any complaint. He just came for some just a routine refraction. And then we found that he has the fundus picture. And then on retrospective asking, the wife said that, yeah, I have noticed he's not very comfortable at night, but the patient himself did not really complain of anything. It was a non-consanguineous marriage of his parents. There is no other family history in the patient side. The best corrected visual acuity was 6/9 with a -3 myopia in both eyes, and he had a normal color vision. This was his fundus picture. It doesn't look very classically like a choroideremia at this stage. It has these nummular pigmentations. So I was wondering whether it is RP or something. OCT showed a bit of macular thickening. So this actually made me think of something like CRB related RB. ERG was flat. The scotopic and photopic both were flat. And then his genetic test came out to be positive for this CHL. A second case for 43-year-old male, he did complain. He came with a complaint of night blindness and since early childhood, and recently had also started experiencing visual field constrictions. He was also product of non-consanguineous marriage without any family history. Same myopia with 6/9 vision in both eyes, normal color vision. Now this looked more like a choroideremia, an advanced disease probably. Again, a flat ERG in both scotopic and photopic conditions. And then a CHM variant, which was pathogenic. Case 3 was a 28-year-old male, again complaints of night blindness.
Tanmayi, sorry. Variant same or variants are different?
No, different. It was a different one. This was a nonsense, and I think that was a deletion. Yeah, this one was a 4 base pair deletion.
Okay.
Case 3 was a 23-year-old male, again similar complaints of night blindness and progressive visual field constriction. Similar picture of non-consanguinity of the parents, no family history, and again a 6/9 with a -4 myopia with normal color vision. Now he had an even advanced fundus picture like this. OCT did show a little bit of thickening. The left eye picture wasn't very clear. He had done these tests elsewhere actually, so we didn't make him repeat them here. Flat ERG, and this is another variant. All 3 had different variants. So this was also a nonsense one. Now this patient said that his sister is married and wants to start a family. So what about it? I said then you have to get her also tested because she could be a carrier, and unfortunately she has come out to be positive for the same variant as well. So now I have called her back regarding her prenatal and pre-implantation genetic testing counseling. So what was common in all these patients? Obviously, we all know it's an X-linked disease. So they were all young males complaining of night blindness and visual field constriction. In spite of the severe fundus atrophy, all of them had 6/9 vision with myopia. So the visual acuity was quite well maintained, and even despite this dramatic fundus picture. So then I found this study about long-term natural history of visual acuity in eyes with choroideremia, a systematic review and meta-analysis of data from about 1,000 individual eyes. What was the purpose of this study? It was just to define the long-term natural history of the visual acuity in untreated eyes that are affected by choroideremia. Because visual acuity is used as the key outcome measure in any clinical trials, but its previous long-term pattern was unclear. So this particular article, it researched 7 electronic databases, and they extracted individual level BCVA data from 1,004 eyes across 23 studies. And they used segmented regression analysis, and a horizontal translation factor was applied to align eyes at comparable disease stages. So these were the key findings, that choroideremia has a two-phase decline in visual acuity. There is a slow phase of BCVA loss during early life, and then a faster decline at around 39 years of age. So generally before 39 years, there is a very slow decline, about 0.33 letters per year. So it is not significantly different. From the no change in some analysis. And after 39 years, it worsens more rapidly by about, say, 1.23 letters per year. And inter-eye correlation was done. BCVA in the right and left eyes showed moderate correlation, indicating some symmetry, but also individual differences between the two eyes. So what are the clinical implications of this? That BCVA alone may not be as sensitive an endpoint in clinical trials to enroll younger patients, because vision remains relatively stable early in the disease. The trials that focus on older patients may still use BCVA decline as a meaningful outcome, because after this age, there is a rapid decline in the vision. So this necessitates that we look at alternate biomarkers, for example, anatomic imaging or other functional measures like microperimetry, to validate early stage monitoring. So other parameters other than BCVA may be better suited for studying in trials that involve early stage choroideremia. So this was the conclusion, that there is a two-phase natural history, relatively stable early phase, and a faster decline beginning at around 39 years of age. So this has an important implication for the trial designs, endpoint selection, and patient counseling in choroideremia. So the goal was to understand the natural course of vision loss so that doctors and researchers know what to expect without treatment. Why was this important? Because visual acuity is often used to judge whether treatments work or not. If vision normally stays stable for many years, it may be hard to detect improvement or worsening in young patients during clinical trials. So knowing the natural history of the disease helps with patient counseling and designing better trials. So this is just a repetition that below, so largely under 40 years, the vision remains stable, and after 40, there is a rapid decline. So why does this matter in real life scenarios? Because younger patients can be reassured that central vision is often preserved for many years, that they are not going to go blind anytime very soon. And it will become more noticeable only in mid to late adulthood. And for clinical trials, it is important because visual acuity is not a sensitive measure in young patients. So the trial designers have to bear it in mind that if you're designing a trial for younger patients, you have to use other parameters to judge the outcomes, like maybe retinal imaging, visual fields, or microperimetry. And visual acuity can be most useful as an outcome measure in older patients. So coming to the chronicles, these are the few of the trials that have been done, starting with 2014 here. This was a gene therapy in patients with choroideremia, initial findings from a phase 1-2 clinical trial. And then there was one more in 2016, visual acuity after retinal gene therapy for choroideremia. These were done in UK. So these showed better, so this was It was a case control kind of a thing. Each trial involved 6 patients. One eye was used as the treatment eye and the other was a control eye. Similar with the third article, which was done in Alberta, Canada in 2018, 2 years. So there was a 2 years gap. The first 2 studies showed definite improvement in visual acuity in the treated eye as compared to the control eye. But the third trial showed almost a similar visual acuity in both the eyes, the treated eye as well as the control eye. I'll just come to the details later, but I'm just summarizing these trials. Then there was a trial in 2019, efficacy and safety of retinal gene therapy using AAV vector for patients with choroideremia, a randomized trial. So this showed that patients, this was a phase 2. So the phase 1 trial and this phase 2, this showed that the visual improvement was sustained over a 3-year period. That's what this 4th article showed. And also that the change in retinal sensitivity after gene therapy was well sustained. And this the 6th article was a randomized phase 3 trial of the subretinal gene therapy, which was published in 2023, so quite recent. And this is the more important one that I will be discussing more in detail. So let's just come to a meta-analysis of the phase 1 and 2 clinical trials. What was just a summary of the phase 1 and 2 trials. So basically, these demonstrated a proof of concept for AAV Rep1 treatment in CHF. So they basically showed that you can treat this condition with gene therapy and it is effective. The difference between anatomical outcomes of treated and fellow eyes was relatively unchanged over the 24-month period. Loss of autofluorescence was similar in both treated and untreated eyes by 24 months. Further analysis is required to assess whether the decline in autofluorescence in study eyes slows following treatment. What is important for us to know is that this meta-analysis showed that the BCVA in the study eye remained stable or improved in most patients following the treatment. So most trials showed a better BCVA at the end of treatment in the treated eye. Those with moderate vision loss at baseline demonstrated a higher mean gain in vision at 24 months compared with all patients. So those that had the severe the vision loss, better was the gain in visual acuity. A clinically significant improvement of 15 or more ETDRS letters was achieved and subsequently maintained in 3 patients at the 24-month time point. This may reflect the clearance of toxic intracellular debris by the functional Rep1 that improves retinal cell function. Adverse events were consistent with expected events following vitrectomy and RD procedures. These phase 1 and 2 results support the continuing phase 3 development of the treatment for CHF. So phase 1 and phase 2 just said that it works. You can go ahead with a phase 3 trial for further evaluation. And then this was the article that describes the progress, potentials, and pitfalls of the trials done till date. So it's just a review article, which I would like to discuss more in detail. Should we pause for any discussion or should I continue?
I think you can continue. Are there any questions from the other participants?
Hi, Dr. Shalja and Dr. Tanmayi. Avinash here. One question. So in the studies, have they not talked about whether night blindness has improved or not?
No, that's the thing. That's what this article will further describe now. That why only BCVA was used as the endpoint and how that is not the most correct and what other parameters need to be checked. So that will come in the subsequent discussion. But they have not checked about night blindness. They have spoken about testing for microperimetry and the autofluorescent area of the retina, which is preserved or not preserved, but they have not spoken about night blindness.
Okay. At least ERG changes?
No, ERG changes have also not been mentioned.
Okay, thank you.
Yeah. And Tanmayi, as you mentioned that the BCVA is not much relevant. I mean, the changes cannot be documented or correlated with the gain in function up to 40 years of age. So most of these trials are beyond 40 years of age, or they have included patients less than 40 years of age also?
They have included patients less than 40 also. It starts from 30. So the first 2 trials, the phase 1, phase 2, they were 30 to 60 age group was there.
Okay.
But all of them have used BCVA as the
Yep.
endpoint.
Okay.
But very young patients were not, that also this article describes that why young patients were not recruited. So we'll just come to that discussion.
Yep.
So why is this paper important? Because this is the most advanced gene therapy program after Luxturna. This was the largest phase 3 trial in choroideremia. It defines why regulatory approval failed despite biological success, and it provides a blueprint for future retinal gene therapy trials. So we all know it's a rare X-linked retinal degeneration because of this REP1 deficiency. There is a progressive loss of RP, photoreceptors, and choroid, and there is severe lifelong visual disability, and it's a healthcare burden. REP1 is required for the RAB GTPase prenylation, which regulates intracellular vesicular trafficking. So because of this defective trafficking, there is RP dysfunction and hence secondary photoreceptor and choroidal degeneration. So the article also states that choroideremia is an aging disease. There is premature aging of the RPE, accumulation of lipofuscin vesicles, delayed phagosome degradation, and it resembles the mechanisms seen in ARMD. So what is the rationale for gene augmentation in this or gene supplementation? Because most mutations are null mutations. So the gene supplementation can restore the REP1 gene, the REP1 function, the protein function. And it's the small choroideremia gene complementary DNA. It's easy to fit into the AAV because of its small size. And subretinal AAV does achieve a high RPE transduction. So it's a good candidate disease for gene augmentation therapy. So the trial was, it tested the gene therapy of Timrepigen and Parvovec. It was a randomized control phase 3 trial. It compared subretinal gene therapy versus no surgery. And the primary endpoint they wanted was of more than 15-letter BCVA gain at 12 months. So this was just the flow chart. About 239 participants were screened, and out of them, 169 were recruited for the trial, for the phase 3. In that, untreated were 66. And the treated ones were divided into low dose and high dose. The low dose were injected with about 10 raised to 10 viral particles, and the high dose was 10 raised to 11. So 62 controls completed the study, 34 low dose candidates completed the study, and 65 high dose candidates completed the study. And they were randomized as 2:1:2 allocation, high dose, low dose, and control. Oh, sorry, what happened? Okay. So here we have it. Eligibility was adult men with genetically confirmed diagnosis of choroideremia, BCVA of 34 to 73 ETDRS letters, which corresponds to about 69 to 660 in the study eye. Proportion of patients with the primary endpoint was how many patients gained more than 15 letters on the ETDRS chart in a 12-month period. And the secondary endpoint was maintenance of their vision, or proportion of patients with more than 10 letter gain in BCVA, or proportion of patients with no decrease or less than 5-letter decrease in BCVA. So basically preservation of vision or a lesser gain of BCVA were the secondary endpoints. And also safety was assessed, overall adverse effects leading to discontinuation, and ocular IOP, slit lamp, lens opacity, fundus and fundus photography, all this was done. And endpoint reached at 1 year. So it was, the endpoint was of 1 year. So what were the outcomes at the primary outcomes at 12 months? The control group lost they lost an average of 2.3 ETDRS letters at 1 month. The low dose group lost only 1.5 ETDRS letters, and the high dose lost minus 0.3 ETDRS letters. So the high dose group fared the best. They lost the least number of letters over the period of 1 month. And the high versus control was a difference of 2.1 letters. So what is the interpretation? The primary endpoint was not met. None of the participants had a 3-line or a 15-letter ETDRS increase in their best corrected visual acuity, but all the secondary endpoints were met and they favored treatment. That is, at least some of them had more than 10. They did not have 3-line gain, but they had 2-line gain in visual acuity. The treated eyes outperformed controls even in spite of the surgery. Now you expect the surgery to cause a foveal detachment, macular detachment. Still, the operated eyes performed better than the control eyes. And even if it preserves the vision, it is meaningful in a degenerative disease. All these progressive diseases, they don't have any treatment. So even if the visual acuity is not improved, at least if the visual acuity is preserved, it is still an advantage for the patient. But then why did the trial fail the primary endpoint? Why did no patients gain 15 letters or 3 lines? Because patients with advanced disease at entry only were recruited. They have a degenerated foveal RP, which limits their transgene expression. Their RP, as we discussed before, the RP is already aged. It's a chronic aging process. And that RP now is not able to respond to the gene therapy very effectively. It's a slow disease progression, so it makes short trials insensitive. They have considered only 1 year, whereas this disease is a long progressive disease. And because it's a rare disease, the sample size must have been limited. There was a regulatory mismatch. FDA requires more than 15-letter gain, and the European Medical Advisory accepts a 10-letter gain also. So, but because the investors were US based, they considered the FDA regulation, and that's why they said that we cannot go ahead with the therapy because it did not meet our primary endpoint. So approval may depend on geography and not actually the biology and the scientific success, because even a 2-line improvement or preservation of vision with gene therapy is very good in such a disease. But because the primary endpoint of FDA was 3 lines gain, this gene therapy failed to make it to the FDA approval. So choroideremia progresses extremely slowly. So short trials cannot detect stabilization easily. True benefit may require at least a 10-year follow-up, but then it becomes very expensive to keep these trials going on for 10 years. So that's why only 1 or 2 years are given for each trial endpoint. And this may also be a hindrance to the FDA approval of such a gene therapy. So as we discussed, Shailja, you were asking, were young patients recruited in the trial? No, because firstly, they had better vision. They had about 6/9 vision, and these patients had less than, say, 6/12. So because the endpoint was a 15 letter gain or a 3-line gain of visual acuity, if your vision is already 6/9, there is not much scope for a 3-line gain. So there is a ceiling effect of best corrected visual acuity. That's why, and also the ethical consideration that if the visual acuity is well maintained, should you enroll a patient, should you subject this patient to a surgery which could technically, reduce the visual acuity due to the surgery. So because of these ethical considerations also, young patients with early stage disease were not recruited. In fact, they were the ones who would have benefited the most from preservation of their intact retina. So that's why this is a limitation again of the trial, that only the late stage, advanced stage cases were included in the treatment, and their RP was already at an end stage, so there was limited scope for recovery.
That's a problem with most gene
Yes.
therapies,
Yes.
the more benefit is expected in patients with early disease,
Correct.
but they are not recruited because of the fear of side effects or complications causing more harm.
Yes.
Even if in 1 or 2 patients it may be harmful if they are retaining whatever. So that's
Right.
And by the time it increases or the vision drops, the cells have kind of become dead. So the response to gene therapy reduces.
Right. That's exactly what the authors are saying happened with this study as well. So they compared it with an RPGR thing also. So in choroideremia, there is a chronic RP failure and aging, whereas in RPGR related RP, there is rapid photoreceptor cell loss. So you see that they are suddenly worsening. RPGR is one of the worst forms of RP because there is rapid central visual acuity loss also. But because of this rapid photoreceptor loss, RPGR patients are more likely to show anatomical recovery. And maybe RPGR trials are getting better gains than choroideremia for this reason. So now we need better endpoints because BCVA has a ceiling effect in early disease. If a patient has 6'9", he will not be recruited in the trial because we can't expect him to gain 3 lines. It is also insensitive in slowly progressive disorders, and structural biomarkers are needed for early intervention trials. So then the authors suggested a smooth zone concept. That is a homogeneous short-wave autofluorescence island of the retina, which represents the healthy RPE, which is not yet affected. This part shrinks as the disease progresses. I will show you a picture in the next slide. And this correlates with the intact ellipsoid zone on OCT. So basically here we see in the top figure on the left, this is the smooth zone, which is delineated. The visual acuity is 6/7.5. And in the picture below it, so this is the right and left eye of the same patient. Here we can see in the above two pictures, this is a nice circular smooth zone of autofluorescence. And then here it shrinks. Beyond that, it shows a mottled appearance. But the vision is still okay. It's 6/6. It's 6/7.5. It is 6/6 here. But then this smooth zone has shrunk, which means that this is a more advanced disease. So if we use these parameters as an endpoint, it could probably fare better. So the smooth zone gives an indication that at that area in the retina, the RPE health is preserved, whereas the mottled zone suggests a stressed or degenerating condition. Here, if you compare it on the OCT, the ellipsoid zone integrity is also better maintained and it is disrupted in the mottled zone. So the therapy has a high potential in the smooth zone as compared to the mottled zone. Now, smooth zone is also applicable in early stage patients. It is a direct measure of degeneration rate. It avoids the BCVA ceiling effect and may allow smaller, shorter trials. So you don't have to wait for the vision to deteriorate over 10 years. You can just monitor the island of this smooth zone and see whether it is shrinking over a period of year or it is well maintained after a gene therapy shot. So what it can help is optimize with patient selection. Instead of selecting patients based on visual acuity, we can select patients with a preserved smooth zone, target the viable RBE and photoreceptors. So we avoid the end-stage degeneration altogether because those with the smooth zone have the highest chance of benefiting from the gene therapy. So all this can maximize the biological response as well. Then they were also exploring other options because subretinal, it's a full-blown surgery, but it has the best RPE transduction and it is an immune privileged site. Intravitreal is very easy to give, but then there is a barrier of the ILM and there is a higher chance of immune reaction. Suprachoroidal is, it's technically it could work, but then there is rapid clearance because of the high vascularity of the choroid. And also in choroideremia, the choroid is thin and absent in many places. So suprachoroidal is technically challenging. So in conclusion, subretinal gene therapy is still the best route. They suggested a 2-step bleb approach. And then, so first injecting balanced salt solution, creating a bleb, and then the vector injection. The retinas are extremely thin, so we have to be cautious. There is a high risk of foveal stretch injury. And intraoperative OCT should be made mandatory. So there is a standardization over all the centers. So microscope integrated OCT improves precision, allows real-time monitoring of the bleb. Robotic systems may improve consistency, and surgery is a major determinant of success. So all these precautions will further enhance the effect of the gene therapy. CRISPR has also been suggested as an alternative for gene augmentation. It could offer permanent genomic correction, but they have raised the risks of off-target effects of the Cas9 enzyme. Also, it is challenging to make a particular target for the this CHM because there are so many mutations that are involved that it's difficult to make a particular target of CRISPR. So currently gene augmentation is more practical. Choroideremia is a health economic burden, so it justifies the need for disease modifying therapy. These trials also give us lessons for polygenic retinal disease because the vector design principles are transferable to polygenic diseases. Imaging-based endpoints are critical. Long-term safety data can be invaluable, and it forms a framework for complex disorders. So choroideremia trials are important not only for monogenic for choroideremia, but they give us a framework for polygenic retinal diseases as well. So what we can conclude from all this is that gene therapy is biologically effective in CHM. The trial failed due to the endpoint design and not science. Early treatment and better biomarkers are essential, and the smooth zone may unlock future regulatory success. Thank you. So probably Luxturna ke baad we could have seen gene therapy for this,
Yeah.
but because of certain issues, it was not FDA approved.
Thank you, Tanmayi. I appreciate a lot of research and digging and reading up for this lecture. Thank you so much. And it's one of the most exciting ones and OGIG has held. I think these are new things which we have never discussed before.
Right.
So thank you so much. So a lot of learning points. First and foremost is that, visual acuity is not like a good parameter for measuring the progression in CHM at least, right?
Yes,
So
yes,
that is
yes.
something that was new and what I've learned. Another point was that you need better markers. One of them could be the smooth zone,
Smooth
the
zone.
central one in the autofluorescence. Apart
Yes.
from that, what was the other evidence related to microperimetry?
Some articles did measure microperimetry, especially I think the phase 1 and 2 clinical trials.
Mm-hmm.
They had measured the microperimetry retinal sensitivity in that area,
Mm-hmm.
which gave mixed results. They were improved in some patients and not so much in the other. But not much was spoken about it. There was just one line saying that microperimetry was also done. But what Dr. Vinash suggested is maybe
Night
night
blindness.
blindness. Yeah, but that is again subjective. Maybe if we could have some objective parameter to measure the night blindness, dark adaptometry or something, then
Yeah.
it could. But what they did for Luxturna, the minimum luminance mobility testing,
Mm-hmm.
that could work for this also. Like for the Luxturna and even RPGR recruitment, what they do is they make them walk through a maze
Yeah.
in decreasing lighting
Mm-hmm.
conditions. So they have not, I didn't see any trials speaking about this luminance motility test.
Maybe because the central vision is not that bad in them, but yeah, if it's under dim illumination.
Yes, yes. So that could help us gauge the improvement in night vision or dark adaptation, what was used for Luxturna and RPGR, what was going on. Maybe that they can, instead of BCVA.
Mm-hmm. Yeah. Anyone from our participants? Retina colleagues, speech colleagues.
Hi, Dr. Shailaja. Hi, can you hear me? Good evening.
Yeah, hi Deepika.
Hi. Thank you, Dr. Tanmayi, for the good overview of all the trials.
Yeah, thank you.
I wanted to ask on this phase 3 only, the phase 3 trial of Robert McLaren's group. I think they
Yes.
had also, as I remember, I did not read it recently, they had also mentioned about, I think, retinal sensitivity, mean retinal sensitivity or something.
Yes.
How
So
is it like? Can you tell us more on that? I'm not sure.
mean retinal, then I'll have to just quickly pull up the article again. But there wasn't much this thing about the retinal sensitivity. Just a minute.
I think that is one of the secondary measures also, which they had considered. Maybe I'll also see.
Yeah, must have done because most of these trials they at least try to measure everything that is possible.
True.
Because they're investing so much, so there's no harm in doing everything. May have done even
Yeah.
energy also, we don't know. But again, I don't think so. Lot of ERG changes over the years in CHM? Are there? I mean, does
No,
the
because
ERG also keeps
in my
falling, or
three
in the
cases,
beginning only the ERG is like that and stays like that?
flat. It was flat. In all my three cases, it
Yeah, in
was
your
flat.
patients was like that, right?
So
So
then we
maybe
don't know about the sensitivity. Dr. Deepika, I'll just read the article again, but their primary and secondary endpoints just mentioned BCVA, and that's the reason it failed, because they just measured the BCVA and said we want only a 3 lines increase in the BCVA, and because the trial did not meet that, it failed. The secondary outcome was just preservation of vision. They must have done retinal sensitivity, but that was not used as a outcome measure. So maintenance of vision and proportion of patients with 10 letter gain and preservation of vision or decrease less than 5 letter. So they just concentrated on BCVA, but still I'll again read it in more detail and just get back on the retinal sensitivity part of it. Because I read so many abstracts today again that I'm
Possible. Yeah. Thank you. Thank you.
yeah, okay. But I'll go through it and revert.
Thank you. Thank you. I'll also read up. Could not
Yeah.
read. And I would like to add one point on ERG, since everyone is discussing on usefulness of full-field ERG in measuring efficacy. So as we all just know, you both said that ERG will be quite flat very early in the disease. And with the treatment of gene therapy, where we are targeting a certain amount of retina, maybe it is very less localized.
yeah,
Expecting a global function in a retina which is
correct.
already structurally so much damaged, I think it is not a good outcome measure.
Good outcome measure, yeah.
So it is even in the Luxturna trial, they did not include ERG to be as one of the even secondary or tertiary outcome measures. It was not there. It was what included was full field stimulus test, which will pick up the most sensitive retina to give up the response. Like it picks up the retinal threshold from the most sensitive retinal cells. And post gene therapy of Luxturna, it was noted that the retinal sensitivity improved drastically by the measure of full field stimulus test, uh, majorly in the regions where the Luxturna was injected. So fulfilled a generalized summative response. I think it will not help in these degenerations where structurally there is so much damage, because we know that in RP patients also there is central retina which is preserved, but wherever there is more than 60 to 70% of the photoreceptors are gone, ERG will become flat. For us to gain that back from these kind of trials is practically not possible. So that's why ERG will not be helpful. Microperimetry, I think the sensitivity will definitely help. There's always a large and good discussion that this ETDRS 3 line improvement never applies to IRDs, because there's a lot of other functional things which are involved. The multiluminance mobility test, which simulates the real world scenario, is the best way, like Dr. Tanmayi was mentioning. I think so. Yeah.
Yes. So I think in Luxturna, the visual acuity is so poor that they don't concentrate on as much on the like in LCA.
Visual acuity as such, just the mobility and the function.
Correct. So LCA, they don't expect the visual acuity to improve. It's just the dark adaptation and the, as Dr. Deepika said, the multiluminance motility and the sensitivity. The full field sensitivity of the retina is expected to improve and not the visual acuity. So the endpoint of Luxturna, I don't think was visual acuity.
Yes, no, it was not the primary outcome. The primary outcome was always increase in retinal threshold sensitivity, which was measured. And secondary outcome, at least the BCVA remains stable. And always the Luxturna trial, when it is explained to the patients also, it is told that it is not about improving the central vision. It is about improving the retinal sensitivity to dim light vision. Because in RPE 65, where the enzyme is working at the RPE, it regains the retinoid recycling, and it regains the dim light, the dark adapted vision. So that's what is proposed mechanism, and that's what has helped and made wonder for patients too.
Correct. So I don't know why the same thing cannot be applied for choroideremia, because night blindness is a major issue. I mean, it's the presenting complaint in choroideremia also. So if that could be used as an endpoint or outcome measure, maybe it will help.
So in RP, Dr. Shailaja, you're muted.
Oh, sorry. Yeah. I was just saying that in choroideremia, because the central vision also drops, and they had selected patients who had a moderate vision loss, central vision loss. Maybe the improvement is measured better, like a more objective rather than mobility. Maybe that is why it's one of the selected
Yes, but in
parameters.
addition to that, maybe as a secondary outcome,
Yeah,
this
it
should be
can be done.
included
Yeah.
because that affects the patient's quality of life and real world scenarios are simulated as well.
Yeah. You were saying something,
I have
Deepika?
a question. I have a
Yes.
question.
Yes, Dr. Smita.
Once like Lakshana is approved now, so is it possible to do it even in children who are a little better visual acuity than compared to adults? Or is it still not, you have to follow the same criteria what they used for trial when you are offering it as a therapy, not as a trial?
Ma'am, Lakshana, you're talking about?
I'm talking about Lakshana, since this is FDA approved. Now,
Yes.
LCA with RP65 can have all kinds of variations. Sometimes they come to us at age 3 with really flat, completely flat ELGs and very poor vision. But if you pick up the child early, say a sibling who is not looking that bad, but the criteria, can it be offered as therapy? Even if it does not fulfill the criteria, whatever they used in trial.
I don't know, frankly, because I don't know. Dr. Deepika, are you aware of?
Yes, I would like to add on that. So post the phase 3 trial for the real world scenarios, the guideline was a patient with biallelic RP65 mutations and vision of less than 6/12, as I remember. So, and in general, Lakshana, when advocated, like Dr. Shailaja was mentioning, in early stages, when there is enough structure function dissociation, that is when it makes wonders. When we go for the later stages, suppose the retina has degenerated enough, vision is very low, we don't have enough photoreceptors remaining. Actually, few studies, even we had worked during my fellowship on fewer cohorts of older age patients, where actually it did not improve so much of retinal sensitivity. So the earlier the better. And the youngest, as I remember, is I think they had given, I think it's UK cohort or US, I don't know. I think it was 3 years or something, 3 years old kid or something. The youngest I have seen is 8 or 9 years, which we had given in Hospital for Sick Children, Toronto.
Yeah. So FDA approved it for children as well as adults.
Yes.
I'm not sure in India it has been approved for therapy. I mean, like direct therapy. I think for some clinical trials, some approvals were there, but nothing is going on as of now.
Mm.
Do you
Yeah,
know
true.
anything, Deepika? Yeah.
No, true. I think 2, 3 years back, notice had come.
Yeah.
A lot of discussion had happened, but they did not. The reason was they did not find enough number of
Patients with
patients with genotyped
RP65.
RP65.
Yeah.
At the same time, I think it was also the market which was driving, which I think we don't have government sponsoring here. Maybe
Yep.
those two reasons. And what I heard in the last meeting, when I met Dr. Meenakshi Bhatt, if the company is registered in India and the disease is coming in rare disease and the cost is less than 50 lakhs,
Relax. Yeah.
then we have still provision to apply to government that yes, this therapy can be helpful for this patient.
Yeah, but that is for the diseases listed in the NPRD. Unfortunately, LC is not registered.
Registered.
But yes, if we have more patients and
Uh,
collectively we have a therapy, then we can plea for registration in the NPRD, and then it will come in that. So those kind of possibilities are there. That's how they got so many other diseases onto the NPRD, which is a national policy for rare diseases.
True.
My experience with LCA is that by the time they reach us for diagnosis, that time itself they are very
Advanced.
advanced. Yeah, I mean at the age of 1.5, 2 years, I don't know if, and we don't see RP65 also that much in our population. That is also true. So I don't know, 8 and 9, by the 8 and 9, child is almost blind. So I don't know if it really will. I've never seen a child with LCA with 6/12 vision in my experience, ever.
Yes. Also, LCA is largely, I don't know, it's a non-progressive in the sense it's very severe to begin with, and then there are stages. So, ma'am, what you're saying is by the time they are 8 and 9, but I think if they are bad from the beginning. Or then they are
exactly. That's what I'm saying. I have
for a
never
long
seen
time.
an LCA child with even 6/36 vision.
Yes, barely 660 sometimes.
660 is the best vision I would have recorded in an LCA case.
Correct. That's why they don't concentrate as much on visual acuity. Then it's more about the sensitivity.
Okay.
I think the
Thanks.
criteria mentions viable retinal cells.
Yes.
Yeah, I don't know how they measure it. I'm not very sure. Maybe it's through autofluorescence
No, it's
and
OCT. It's OCT.
OCT, and OCT.
It's OCT.
That if they're anatomically looking okay and or autofluorescence is not like a dropout or they're not atrophic areas, then probably they're viable, but they're not functioning because the product, is not being generated because of the defect in the gene. So if you give the correct gene, then probably the mechanism is there to produce the product and make it function. The photoreceptors are there so that the gene product will go and act there. But if it advances in the sense that, the retinal cells, they are dead kind of a thing, then photoreceptors are dead, then probably it won't work. That is what they have mentioned in the gene therapy, the guidelines.
Also, if it's a child with LCA who you're treating as an adult, it's obviously the amblyopia issue also. I mean, LCA is always by birth and it's in children. But then, how do we go about, or what is the criteria for treating? As Dr. Sumita said, in children, the threshold should be lesser and they should be treated faster because
earlier, yeah.
Then the amblyopia also sets in.
Yeah. That's for all disease, as I mentioned.
All of them.
So those where that is why it's more lucrative for diseases where the onset of symptoms happens at a later age, because by the time some development of vision has happened and whatever you intervene is supposed to be more effective.
Yes, correct.
That is why maybe even CHM is better or Stargardt is better, where you have some preserved vision and the amblyopia is not set in.
Correct. So patients often ask that science has advanced so much, why isn't there a therapy yet for this? Now this is a good thing. I tell them that see, this trial has shown good effect, but there's so much bureaucracy and so much financials and pharma investment involved that science has progressed, but these are the barriers.
Agreed.
Thank you so much, Dr. Tanmayi, for the talk. And it does give a lot of hope for the choroideremia patients. I just wanted to ask how to look for clinical trials. Do you regularly check clinicaltrials.gov, or is there any other way, or you follow the publications for the same? And what to tell the patients, how can they also keep a track of the same for enrollment if possible?
So yes, I did go through clinicaltrials.gov, and that's when I found all these studies that these are the completed trials, phase 1, phase 2, phase 3, and then they have been published. Not for this, but I have emailed to the ongoing trials of ARMD and a couple of ABCA4 and a couple of other diseases. But all of them have written back saying, no, we are not recruiting patients from outside the US, outside China. So they're just not recruiting international patients. So I don't know what is the provision for Indian patients for trial enrollment.
Right. So even if they are affording and choose to go there and live there for a year, but still nationality would be an issue, right?
Yes. So because most of these are sponsored trials. There is one I found, which is a stem cell therapy. They are doing it in Dubai and USA. So they don't require even a genetic test, and it is applicable to all genetic diseases. It's a stem cell procedure, like they'll extract it from your hip, the bone marrow from the hip, and then inject a stem cell injection into the retina. That they said we will recruit, but then it is entirely self-funded. I also gave this option to a few of my patients. And
However,
the
won't that be ineffective given that even that bone marrow cell would have the same mutation, right?
I don't know.
Because it's germline, it is from the conceiving point itself.
Correct, correct.
No, Maitri, actually, the way it works, I think we need to mute somebody. Okay. So, I think the stem cell therapy and how the gene therapy targets the defect is quite different. So, gene therapy would go and, change the gene, and then you depend on the retinal cells to produce the product
Right.
and,
Yeah.
use it up.
Hmm.
Whereas stem cell therapy, it goes and replaces the retinal cells. So whatever is the gene defect, you get a new set of cells which are which are not defective, which are functioning, and they kind of, then help in improving the vision. Of course, it has its own set of merits and demerits, but that is why it makes it, gene agnostic. And you
Correct.
don't
So
need
it doesn't depend
a
on the
specific,
mutation. Yeah.
yeah.
So then, these, just for my knowledge, so when these new cells or fresh cells are implanted, they also have a life, like when they also reach say 25 years, then that mutation again will start acting, or is it like cured
No,
in that
not
sense?
that mutation, but yes, they do have a lifespan within the eye and they need replacement. That is one of
Okay.
the problem. And then again, you have to deliver it in the subretinal space. That is also one of the problem, that every time a surgery is required.
So the Dubai trial would cost about 25 lakhs, which is
Per
still
injection,
per
per eye, is
yes.
it?
No, I think both eyes.
Dr. Tanmay, is this the Scots 2 trial that you're talking about?
It's let me see. Yes, I think stem
Yes,
cells
even
for
I had written to him about one of our patients. They have,
Stephen
they have
Levy.
multiple, yes, they
Stephen
have
Levy, yes.
multiple centers in the world, some in
Scots
Dubai,
2.
Singapore,
Scots 2.
USA.
Yes.
Yeah, and when you write to him, like if you have a retinal dystrophy patient, you can write to him for specific diseases and he'll send you his data.
Yes,
And
he
yeah,
said.
he doesn't have his own funding, so he says that if the patient is willing to pay, they can go. Even
Yes,
when I did the calculation, it was something around 27 lakhs. So a
correct.
few patients we have told, but most of our patients are not that affording.
Yeah.
But for others, if anybody is willing, they can see.
So there are trials, even in gene therapy, who accept patients from overseas, but I think it depends from center to center and trial to trial. So a couple of patients have referred for this achromatopsia trial in UK, Moorfields. I'm not sure what happened to them when they went there because I didn't hear back from them, but at least they accepted and they asked them to come and show and things like that.
Okay.
Whether they enrolled finally or not, because it was a pediatric patient, so they were saying that their cutoff is 6 years and this child was 3 or 4 years. But the parents were from a good family and they could afford staying there and getting the treatment, so they opted to go. So it all depends upon the trial to trial that is there. Yeah.
Dr. Shailaja, can I
Any other
ask a
question? Yes, Dr. Nina.
So my doubt is like Sumita ma'am was asking about the LCA, no? So what in my short experience, what I have seen is that these the other than the RP65, which is the GUSI2D mutation causing LCA, which usually presents with very poor vision at birth, RP65 still has a better vision, no? I mean, I'm correct me if I'm wrong, the retinal specialist there, because I've seen GUSI2D mutation LCA is pretty bad right from birth. RP65 is not so bad
So bad,
at
yeah.
birth.
And we
They
don't
become
see that much at RP65 in our population. That is what ma'am was saying.
yeah, the ones which I have,
Although,
all those ones which are very bad, like roving eyes and all, the LCA, the typical LCA in my group are all GUSI2D mutation. So can we distinguish anything like that from the the presentation before we doing the genetic study from the phenotype and the presentation that this is a worse prognosis?
In the beginning, I don't think so. Much differentiation between the two. Yeah, later on, RP65 has a little bit more pigmentation, if I remember correctly. I'm forgetting.
Okay.
Yeah.
Because both, as you
And the
correctly
same
said,
thing, the vision is a little bit more preserved. That's the thing.
yeah. So all the ones in LCAs when we did, we got ARGUSI2D mutation instead of RP65. So whether it's just a by chance, I don't know.
No, it's there in literature also that in Indian population it's more of Gusei today. I haven't sequenced so many of my pediatric patients to come to a conclusion, but in literature it is mentioned that way. Deepika, you were raising your hand.
Yeah,
Please just
Dr.
speak up. I mean, no need to raise hands.
No, it's just thing. Yeah, Dr. Rina, like rightly said, it's a very good observation. GC2D is the commonest form of LCA in our cohort. We have worked on small cohorts of LCA. I think from SN also the data is there.
Yeah.
From LVP also there is data where we had found that in LCA, GC2D is most common in our cohort. And definitely these are more severe functional losses to begin with, when compared to RP65, where you said that though the retina is looking like a normal looking retina, OCT shows preserved photoreceptor cells, but the kid has a lot of vision problems with respect to nystagmus, not fixating. So GC2D is another entity of LCA. RP65 definitely better than GC2D. I think in RP65, when Dr. Sumita mentioned also, I wanted to say on that, it was not just for LCA, which was recognized for the trial. It is RP65 retinal dystrophy, which was approved for the therapy. It can be varying from LCA to the
Agreed.
CCOT, early onset severe retinal dystrophy to adult onset, adult with
RP.
RP65. Yeah, few phenotypic clues for RP65 retinal dystrophy to pick up is that they all will have poor autofluorescence because it is involved in the RP65 retinol recycling. So we will not have fluorescence in them. So that's why autofluorescence is also not a good guide to take it as a endpoint measure, like Dr. Shailaja, you were mentioning. The viable retinal sense, which they meant was in OCT, the central macular thickness with preserved photoreceptor cells. And any gene therapy concept is that where we have a lot of functional loss, but there is structural preservation with viable
Preservation.
cells. Those are the key, like RP65. In fact, GC2D also, the same concept applies. I'm not sure. I think there is some technicality with respect to the size of the gene or AV vector, which is limiting GC2D to have the target therapy like RP65.
Did you do any trial for GUSI2D? I mean, is there any trial going for GUSI2D? Because there's a lot of patients are asking.
I know. I'm not sure. Once, yeah, I'm not aware of it. I have to read up.
Yeah, I haven't checked, but you will get the information on clinicaltrials.gov.
Okay, thank you.
There are a couple you can see. Yeah, it is there.
Astenas,
I remember reading
FFP
it once.
Astenas you can check in Foundation
Hmm.
Fighting Blindness. Astena is a company. I
Hmm.
don't know what happened later on. I have to see.
Yeah, okay.
Yeah, thank you.
So good discussion today. Thank you everyone who contributed. Thank you to all the participants. Thank you, Tanmayi, so much for starting this and having this. It's a very great effort, and um, we'll continue this. I think
Yes.
one more thing which we didn't touch upon is optogenetics, which is also coming up, which is
Yes,
again gene
yes, yes.
agnostic. Maybe we can discuss it some other time or with some other disease where it is
No,
applicable.
I
It'd be good
read
to
some
know.
title of a study on optogenetics and choroideremia also, but then
Yes,
I
yes.
didn't included it in this. It would have been too vast. I didn't read it also very well actually.
Yeah,
But
even I've heard a little bit and about it. Even in hygiene, there was a discussion after that. I also went back and saw something. So that looks very exciting, but I don't know how effective it is as of now. But maybe we could take it up next time or something. We'll keep it in mind so that everybody is aware.
sure,
Okay.
maybe we can next talk about Rookie 2D only because if that's so prevalent. as LCA.
Yeah.
Yeah, I think that's a good idea. That's a good idea. I think it will help our patients too. Yeah.
I just have
Yeah.
one recent patient of UC2D, but not many. Is
Maybe
septum90 also common? I've got one patient of septum90 LCA also.
290, yes, is also, I mean, I don't know how common in terms of the but I have also seen a couple of patients. I mean, as I mentioned, not sequence, but uh, data will come soon.
Maybe we could have an LCA as a whole discussion, just to touch upon which trials are going on.
Actually, again, it'll become too broad
Okay.
because LCA is a
Maybe
very
one
heterogeneous
gene.
disorder. It could be better for one gene. Maybe we could actually take up this GUSI2D and see what is happening in that front, because we have it more common, and maybe discuss the genetic landscape so far
Correct.
published in India for
I think if you can,
pediatric retinal
the problem.
dystrophies. Pardon?
Sorry, did I? You could go on, please.
No, ma'am, please say.
No, I think, like the problem with the trials, the problem is all the interventional trials. Many patients are scared to, get in because they feel there is no guarantee that, anything is going to get better, or what if they lose vision? Surgical interventions, most of them shy. So I don't know. So all those things are, they're convincing the patients, but still it will be a good idea. Educated patients may opt for it. So I think if we have an integrated approach, and, we can have some, we can try some trials if it's feasible. At the end of it, that should be also one of the goals of this discussion, that we can try to do something for these patients, because at least, update them of what's happening and give them that option.
Yes, if any of these trials are still recruiting, then we could.
Yeah, because a lot of my patients keep asking me that, is there anything going on? And I always tell them I'll check and revert, and, I'm unable to update them.
Yeah,
Always
good
check
point.
on
We'll
the
try to
clinical
include.
trials, this thing.
Yes.
They can search on themselves. Like these are the three informations which I give: clinical trials, Foundation Fighting Blindness, and there is one called Foundation Fighting Blindness. Canada keeps updating, and the UK registry also. These are all online, easily available. And even now, actually, Google has become so nice that even if you put a trial related to GC2D, it gives up. It gives up
It
phase
gives
one,
up, yeah.
phase 1/2. It gives up. I think that way we can ask them to check.